Hi, my name is Joy.
How you doing?
Destiny and Monica. Welcome to our channel. Okay, let me stop. So for our first question, we are, well, I'll just read the first question. Okay, so what practical skill, tool, insight/insight did you glean from the Suicide Power in Lighthouse video? Do you want to go first?
The PowerPoint I learned. Well, we kind of touched on this last year, but it refreshed my memory about sad persons. I remember all of the acronyms. I remember sex, age. One of them was previous attempt. Basically, looking at what you need to look for and assessing someone with suicide ideation, possible suicide ideation. It's kind of just like a quick tool. If I would actually remember what they were. It's a quick tool to help remember what to look for.
The thing I enjoyed the most was learning how to do the Columbia and being able to do it in class with each other and kind of like run through it at least once with like a colleague to see how it feels to do it. And I really like that anyone can do it, like any lay person. You don't have to be a health professional. So the Columbia is a suicide severity rating scale, and it supports suicide risk assessment through simple, plain language questions. And I found it just like really easy to ask the questions. Like it was easy to make it into a conversation. It wasn't like one of those weird assessments where you feel really uncomfortable asking the questions. Like like we do some assessments now where it's like, have you ever, is someone on the streets hurting you or forcing you to sell your body for sex? So it doesn't feel like one of those awkward questions to ask people. It's a lot more
straightforward.
It's a lot more straightforward. Like it's definitely not sugarcoating anything, but it's just like a very real, reasonable tool to use. And it's also something that we use at my internship. So I had like the week that we did the training in class, I had a training for it at work on like how to do it with clients. And it was really interesting. So it was good to run through it in class and then like do it at internship where I was like, oh yeah, like I know about the Columbia. Yeah, oh yeah, I've done it before with someone in my class. So
did you have to use it at your internship?
No, actually. Well, most of my clients are babies. Well, not all of them are babies, but a lot of them are babies or toddlers or young kids. But a lot of them have tracheostomy, so they can't speak.
Oh, or they can't cry.
They can't cry.
She would have never told us that.
Yeah. I know. Now I'm really upset.
But just just keeping in the back of my mind some of the aspects of the Columbia rating scale, like whether or not they actually have access to the thing they want to kill themselves with, or if they have a physical or specific plan, stuff like that. Those are gonna help me like weed out who really needs to be assessed and who doesn't.
Yeah, I haven't had to use anything like that at my internship. Yeah, I don't know. You were there before, so I don't know if you got the chance to use it.
Too.
Well, still, but they're a little bit older, so they could do.
You might be able to do it with parents.
Parents, right? Yeah.
But I never had to do it with the kids.
Yeah, I know they have like CDI assessments, but I don't know how young you like what the cap off is for that stuff. What I took away from the PowerPoint was it said in there, suicide victims are not trying to end their lives, they're trying to end the pain. I think that was just a nice way to reframe, thinking about, what our positions are when we're encountering people and how we look at them. And I think sometimes suicide victims get like this really terrible rap, not just, from what we see like on TV or what we hear about like in the news or like how things might be explained like in the classroom, like growing up, like if something were to happen to a peer or anything like that. They don't really explain the difference between like someone like wanting to end their life versus like someone wanting to end their pain. Like they don't reframe that. So I think like when I like was growing up, like I just kind of looked at it as someone who wanted to end their life and like didn't want to live anymore. I knew that was sad, but I didn't think about like the emotional like impact behind that and how it's really just like I'm in so much pain that like I just want it to stop, and it makes but to me, it also makes it feel like they can be supported. Like it's not like, oh, I just want to end my life because I don't want to live my life anymore. Now, looking at it the way that it's in the PowerPoint, it's, I'm in so much pain emotionally and physically, and I don't want to be in it anymore. Now I feel like it's not as scary to have a client who might be, going through suicide, because now I can say, like, okay, there's something that I can, So that's kind of what it made me feel like. And it made me more empathetic too. So, yeah. Second question. In your course of treatment with a client at your agency, you feel it would be helpful for them to receive psychoeducation on the ACE study. Explaining to a classmate in your group as you would to a client. Be succinct and clear. Use your agency as context. Each person in the group should take a turn. So, who wants to go first?
I'll go first.
Okay.
Who wants to be my client? Okay. So it says agency in your context, so I'm going to assume that you were homeless, Destiny. Yes. Okay. So, hi, Destiny. Thank you for coming in today. Hi. So I wanted to briefly share with you something that I think that might be helpful for you to know. So there's a study done not too long ago called the ACEs study, and it stands for Adverse Childhood Experiences. I know you've told me a little bit about what's gone on in your past, and so I just wanted to share this information with you to see if you had any thoughts about it. So essentially, they found that people who had experienced trauma in their childhood were more predisposed to certain risk factors or diseases in their adulthood, like heart disease or even suicide and things like that. And a big takeaway from that study is, if you are someone who has experienced adverse experiences in your childhood, maybe it was witnessing domestic violence, maybe it was childhood sexual abuse, or maybe it was exposure to drugs and alcohol very early on in your life. It doesn't mean that you are guaranteed to have worse health outcomes in your adult life, but it just means that now that you know that, you can take measures to take better care of your health. Yeah, so maybe we can talk about that, what that might look like for you. Okay.
Beautiful.
Okay.
I really connected with that character.
We're going down.
You'll be my client or you be my client?
Whichever.
Am I a parent?
Yes, you're going to probably be a parent.
I won't be a baby.
I can be a baby.
I literally have only met one patient I could talk to. It was 13 years old. Okay, so you're a parent. You were in Texas Children. You are on the TICU floor. Your child is probably going to get a tracheostomy. And if they don't have one already. Okay, so I'm going to tell you something because I know that you and your child have gone through a lot of trauma. You told me a little bit about your own past childhood trauma, and your child is currently going through some childhood trauma from being in the hospital in and out and having adverse health outcomes. So there was a study by Dr. Felitti, I believe, called the ACE study, which stands for Adverse Childhood Experiences. And the basic gist of it was that they found that the more childhood trauma you were exposed to, the more likely you are to have adverse health outcomes as an adult, like heart disease and cancer, and even exponentially increase the rate of suicide, which I'm not putting ideas into your head. But childhood trauma like physical abuse, sexual abuse, neglect, or if you witnessed one of your parents experiencing abuse, or if you're exposed to substances as a young person, stuff like that, and especially if all that stuff is unresolved. Basically, what the study found is it will eat at you physically, and it will cause worse health outcomes. And we want you to be healthy so you can take care of your son. So, that study basically is saying that you need to take care of that trauma and be aware of it and resolve it so you can better take care of your physical health as well. Take care of your mental health, take care of your physical.
Snaps. Okay. Okay, so you're my parent, 3-year-old. Okay. So, yes.
Johnny, sit down.
Okay.
Get your finger out your nose. Mommy said that's nasty.
Okay, right on topic. So I wanted to talk to you a little bit about an ACEs study. Do you know what that is? Okay. Okay. So the ACEs study is basically in less complicated terms. It's a study that was made to measure adverse child experiences, like throughout their childhood. And that could range from anything from abuse, like on one end, to just like unresolved challenges at home. And basically what it says is that the more challenges and experiences that a child might be exposed to, the higher impact it will have on his health. So basically what we wanted to do for John, what's your child's name? Johnny.
She just yelled at
I
him.
know. So, basically what we wanted to do with you, Johnny, is to talk about that study and see where it applies, because we want you guys to be strong, healthy, developing beings. And we are not in any worries now, but it's just something that we can do to kind of see where we're at, so we can give you the best treatment moving forward. So.
If I come over there again, Johnny, don't make me get the flip-flop.
Johnny.
I
know. I'm like,
Johnny?
Hello. My favorite line in my internship is, she can say yes and she can say no.
Yeah.
That's my favorite line.
She can say yes or she can say no, and that's okay.
Okay, right. They look at me like, is it really okay? Okay. Question number 3. Why is it necessary, or is it, to understand neurobiology? Use examples of the videos you watched for Trauma Day, Intro to Neuroscience, Dan Siegel, all that fun stuff. So,
Man, I wouldn't say it's necessary, but okay.
I would say it's necessary.
It's.
She's like, I would say.
It's helpful. It's always helpful to have physical science backing it up. It makes it more credible to people. But using like trauma and I remember the fight or flight reflex. There wasn't this video, but I saw another video a while back about similar to that, talking about how stress on the mind is a good thing in short bursts.
Yeah,
short
it's healthy.
It's healthy because it's evolutionary and like it's trying to get you on your feet, get your body moving. So if a bear is chasing
to warn you,
of danger. So if a bear is chasing you, your fight or flight reflex is gonna get you moving.
Save your life.
Save your life.
Yeah, right.
Yeah. But if a bear is not chasing you, but you're worried about your taxes or you're paying your bills and you're
It's
just
that
constantly
toxic trauma.
Exactly. That's gonna deteriorate your body basically.
Right.
Because the brain is not meant to handle that much stress over time.
Yeah, I agree. And one of the things that I think about constantly is what chronic stress looks like for different populations who are like experiencing it multiple, like
imagine students.
Right, students. And like even minorities, exactly, minorities in general. Like when you look at, their health overall, like what population has diabetes problems, what population has heart, blood pressure problems, what populations are struggling with these things. And when you look at that, and you see that a lot of times it's minorities, a lot of times it's women, a lot of times it's students and young professionals, a lot of times,
vegetables.
Exactly right. It's a lot of times it's those groups that are constantly being exposed to chronic stress or trauma-related situations. It really puts things into perspective. And sometimes, like I know something that the research talked about was how like trauma, like how your body remembers trauma. And so it's interesting to see.
The Body Remembers, or The Body Keeps Count, or something like that.
I think it's that. Yeah.
Yeah. So like that to me is interesting because like it also makes me think like as a Black woman, like even in situations where I'm not stressed out, am I still stressed out? Like is my body still stressed out from like
how will you know? Because that's the baseline.
Right. That's
your
scary.
Your brain literally rewires itself to remember how you felt as when you were stressed, and to keep you at that baseline when you are constantly.
So that's why I think, like, is it necessary to understand neurobiology? Like, I would say it is necessary to understand.
I guess.
I mean, especially because, like, if you understand, like, the science behind trauma, so, like, social work, we talk about trauma, how, like, it changes you, like, your triggers, your anxiety, but then, like, if you come at it from, like, a neurobiology standpoint, it's like, here's, like, the evidence, it's valid, like, we took MRIs of people's brains before trauma and after, and it was different. So I think it's helpful, especially when like talking to other people about trauma, especially people who like are like, especially like minority communities or like trauma, whatever. Like that's just my life. It's helpful to like have this hard, tangible concept of like, no, it changes you, and this is how. Right. Instead of just like your ooey gooey feelings, which is a big part of it too. But some people don't really respond to that as much.
Right, and I think it's important because for people who don't understand like why health outcomes are the way they are for different populations, like like marginal like white populations, I think that this is a good base point of learning for them too, because it says that overall stress impacts the body, stress impacts the brain, and which one of us have stress more than the others, or which ones are worse.
Even just like thinking like what you were saying like earlier, as like a Black woman, like your body remembers things. So I'm like thinking about like when we go on outreach, and like I've had several adverse experience with men, like either men like that I know, or just men on the street, like either catcalling or fleeing for my life or like something. So like when we go do outreach, my supervisor is a white male, and he's very used to this environment, so he kind of like like he's super comfortable, he's just chilling, talking to like all of these people, and like I feel like he doesn't understand how on edge I am, and like not because I'm like, oh, I'm uncomfortable around homeless people, but it's like, no, I'm uncomfortable being in a situation where there's a lot of men, and I don't know them and they don't know me, so we don't have a connection where I feel comfortable just like being out. And it's not like I'm out there on my own, like he's generally within like a couple feet of me, but like he doesn't pick up on things. Like literally just yesterday, a man like came up to me, he's like, oh, so where you from? And I was like he doesn't see that as being weird, but like as a woman, I'm sure we've all had this weird guy come and be like, oh, so where you from? And it's like some things just don't translate with like you don't understand why this is a little bit triggering for me, because like I've had these previous experiences because you've never had them, and it's hard for you to understand them.
Right. When I sorry, go ahead.
I was just gonna say, even if that particular situation isn't threatening, it's so similar to
like
previous situations that actually were threatening, and that left a footprint on your body and on your brain that is triggered by similar situations. So you get that stress response, that flight or fight freeze response.
Definitely, like I'm more aware of like who's near me, who's coming up behind me, like where everyone is, like where my supervisor is, so I can like, are you within like shouting or touching distance?
Yeah, I was just gonna say, like when I got my ticket this summer, I was like generally scared when I got pushed. I've never been pulled over before. I just started driving. There was no reason for me to be actually scared of anything because I've never had the experience before. But when I got pulled over, I was like, when I tell you I made some real adjustments before he got up to the car. I changed my trap music to gospel music. I was like, whatever I can do to get out of this situation alive.
That's real.
Like, it's true. And like, I just like, but that's what I was processing, and it was not even that serious. It was a really nice Latino cop who came to the window and was like, "Hey, what's going on?" You know, like very nice with me. I know. And he asked me first, like, "Were you in like a rush?" Or like asked me questions that like really helped me feel, you know, like I was de-escalating. But that. If he would have came any other type of way, I probably would have started crying in the car. Like, I don't want to die. But that's how it felt. Like, yeah.
Because you never know what the situation is going to be.
Mm-hmm.
It could have been completely different.
Could have.
We've seen it.
Exactly.
I wonder if that's like, if that counts as secondary trauma. Like, seeing that on the news and stuff.
Mm-hmm. It's community level, like macro level trauma.
It's vicarious if you're like in it with them and you're like, oh my, empathizing really hard.
Mm-hmm. Yep.
We're really on number 4.
How
much time is it?
Oh my gosh, we have a lot left.
I know.
Okay, so
how long is the video so far?
We're on 21 minutes.
Okay.
Sorry, Professor Paldas. Okay. So, how would you engage in civil dialogue with someone who believes the DSM is irrelevant and antiquated system?
Honestly, sometimes I believe that too, but for the sake of this question, I'm going to say that there are many misconceptions about the DSM, such as like it's antiquated and irrelevant, and that diagnosis someone is putting them in the box, or everything's a diagnosis now. Like, I just think in order, just like a physical diagnosis helps the doctor find the right treatment for that person, such as with mental diagnosis. If you don't have the right diagnosis for a person, you might be treating the symptoms but not the whole person and not the whole problem. You might be like, if they're schizophrenic and they're in bipolar, if you're just treating the symptoms but you don't have a label for them, so you don't know which medications or which treatments go with which. You just know that they're acting strange. If you don't have a classification, it's hard.
Especially when people get a diagnosis after at search, like people get a diagnosis right then and there. Like they go see the healthcare for the homeless doctor because they have to have a verification of disability, a VOD, to get on the housing wait list. So we just send them out like trick or treat. Let's go get a diagnosis so we can get you into housing. Well, just for my program specifically because it's PATH, so it's connecting like homeless people to mental health services if that's what they want. And it, like they come back with the wildest things like depression, anxiety / schizophrenic and bipolar, and it's like I think, and they only met them that one time.
Wow.
For who knows how long, and then they were like, "Yeah, this is what it is," and it's like kind of okay because it's helping them get to housing, but it's like also like I always talk with clients, and I'm like, you know, it's okay if you don't identify with this because you don't have to, you know.
Yeah.
You don't have to say I'm bipolar, I'm depressed, I'm anxious.
And I have clients who have a bipolar diagnosis, and they're like, I don't relate with this. Like this is not me, and I'm like, that's completely fine. Like the doctor could have it wrong. You know, it's just for this one instance. Like I'm gonna, you know, put it on the paper. I just want you to know that you don't have to identify with it. And they're like, okay, if it gets me into housing, okay.
Yeah, at my last internship, we, like you guys know, I was only social worker, and so we didn't get into those things. All of my approaches were like, you know, like what can we do, like with our community resources, like to help you. Like that's like really like what went around like my treatment plan because I didn't have like anything to go off of, and I felt like that was really hard because a lot of the students there were dealing with challenges that could easily, you know, been separation, anxiety, and like, you know, different things like that I didn't feel comfortable like, you know, giving a label because it wasn't the environment that I was in. Like it didn't ask for it basically. And so now I found it to be very helpful at small steps because, you know, I'm going to the DSM for every kid and, you know, like I'm writing, and it's never in a way that says like, oh, this is definitely, you know, what he has, let's just, like, this is exactly what it is, and we're just going to treat him like this from now on. But it's more like a baseline, like, here's how you can use it to inform your treatment plan. And I think that is where the debate starts, because I don't think that people look at it that way. I think people look at it as like, this is what it is, this is what you are, this is how we're going to treat you, right? Whereas the truth of the matter is that you're looking at something, it meets some of the criteria, and maybe not even all, some of the criteria, and so we'll go off a treatment based off that. And if that is not it in a couple of weeks, then we can reevaluate. And I feel like that's what the approach should be at all times, and it's not.
It's not always.
Yeah.
Sometimes they do put them in the box and stigmatize them.
I think it depends on the setting. Like,
yeah,
that too. Like if you're in a
hospital,
psychiatrist,
like
psychology, psych ward, like that probably carries more weight than if you're seeing like a social worker
in the school,
in a school or like in therapy. I think different professions engage the DSM differently.
But I wonder how much of a difference that would make, like, in the psych ward and, like, in other places, if they didn't give, like, a hardcore, diagnosis. Like, what would that look like if they treated it as, like, let's see what works.
And I think, like, the last thing I would say about that one, too, is it's, like, I feel like the DSM is, like, a reflection of society currently. Because, like, if you look at past DSM diagnoses, we're like, oh, my God, that's so... that's so messed up. Like, how could they include that? So, like, I think it's just a point in time type of deal. Like, it's gonna change. There's gonna be things that are taken out, things that are lumped together as like they progress. So it's not like this concrete, super definition. Because even the DSM changes, and with it, the diagnoses. So.
Sorry about that. Okay. So choose one of the reading chapters and discuss your primary takeaways. We chose Turner chapter 37 about animal-assisted interventions in social work. My favorite topic. So who wants to go first?
I just remember there were a bunch of different benefits for animals. I didn't know that there were this many benefits. I always knew about the emotional benefits. Well, I didn't know about them, but I knew about them. If that makes sense. Because we have a therapy dog on our floor.
Yeah. What kind of dog is it?
I don't have it with me. I have a sticker of it on my badge. It's a golden retriever.
I knew it. They're always golden retrievers.
Yeah, the only ones we have at our hospital are all golden retrievers.
That's so sweet.
I know, Lavender, like, just golden retrievers in general. Like, the reason I picked her as a puppy is because they just always so happy. Like, she brings me so much happiness. Like, after reading this chapter, I'm like, yup. Yep. She's like my source of sunshine. But something I didn't know is like the cognitive benefits that there are. Like, they can enhance your learning and like all that stuff. And I think it makes sense when you think about like they're helping you with compassion fatigue and they're helping you with like your emotions. So it kind of makes sense that it would make it easier for you to focus. But
yeah, that's cute. So cute. Animal interventions has always been something that I was interested in. I really like, what's it called? I used to utilize the ones on our college campus all the time. Like, they would just have, they would have like puppy days where they get, oh my gosh.
They did it. They did it every finals period.
Every week of finals. So they had a petting zoo. They had a petting zoo too many times throughout the year. We lived out in the boonies, so it was possible. But they had like puppy days where we would come, and there was just puppies. Like, they weren't certified anything, but just babies. Just babies. No, so we had those, and then we had dog therapy, like pet therapy in our counseling offices. So like, if you ever went into the wellness center, like to go see the doctor, to go see the counselor, there's usually like 3 certified dogs like sitting, chilling in the hallway. Or like, I had a couple that were sitting in my session with me because like I was upset, and she's like, oh, let's just bring him in. He'll just lay at your feet and it'll be fine. So like, we had a lot of those. It was really nice. I know. Really helped with decreasing anxiety, and it really helped with my personal stress levels. So that's something that I've always been interested in. I want to get my dog certified for so bad, so especially because he's a people person. Yeah.
I think like owning a dog too, like it's
brings your life.
it's like easier to focus on them. Like when I'm having a hard time, it's like, well, I have to get up because Lavender has to go outside.
Oh,
like I have
yeah.
to feed her. Like I don't have the option anymore to like just lay in my bed and like, be sad for like 8 hours. Like she will not let me. It's like we need to play. Like we need to do this. We need to do that. And I can see how that could be even more exhausting for some people. But like for me, like probably because I love her because she's my pet. I'm like I need to do this for her. So it like helps me just to like. I can't be in the slump anymore. Like it's just not possible.
Yeah, since I got Kovu, I have been on the diet, waking up at 8 o'clock every morning and getting my day started. Right, like let's do this, let's do that. Well, I might as well up. I might as well do everything else around the house that I'm supposed to do. So, yeah, very encouraging.
Yeah, it was the same when I had my cat too. Even though like I adopted him when he was 8, so he was like old and chill. It was just so nice to have like that other like person. I always say person. I know it's an animal, but like the other person.
No, I feel like it's still companionship.
Yeah.
So in the handout, principle, informed, and embodied eclecticism, explain what the synthesis of these 4 factors might mean in your own practice. Share your ideas with your classmates.
So this one was a little confusing, and we didn't talk about it in class. I don't think, did we?
Not a lot.
Yeah. But like what I took away was like it's essentially like your perspective and how it informs like your approach with clients.
Yes, that's
so like I know like the example they used was like Christianity or like religion informs like how I view people. And so like the only thing I could really think of was like I think like my what is it like holistic perspective is like social justice oriented. Like I really like believe in like the true dignity of like whoever the person in front of me is, whether it's an undocumented person, a homeless person, like any even if it's someone that I don't feel like I can agree with, like I still see like the value and dignity in the worth of that person. So like in that way, I feel like it informs my approach by like always having that like unconditional positive regard and like that client-centered approach, like just really high empathy with whatever the person may be going through or experiencing. So it's not like as I don't know, like as formal as like the ones I was reading about there, but like that was the only thing I could think of for myself and how I see it inform my practice, like at my last 2 internships, and just how I interact with people in general, really.
I think the eclectic part of it with the different using different theories to inform it, because not one theory is going to fit. It's not one theory fits all, because some theories are going to contradict some aspects of the person, and where another theory might come in and fill in the gaps, or some theories can completely contradict the person. So it's not accepting one theory for your practice and just sticking to that theory. It's like collecting a bunch of different theories and using pieces, I guess, to make up your own perspective.
Yeah.
Like systems theory is always going to be applicable, I think, but also like empowerment theory, like that's pretty much always going to be applicable in most areas, but just like taking pieces of theories and building your own perspective of how you view people and how you view the world.
I'm going to say informed and embodied, because did you do principle? Okay. Yeah, so I'm going to put these hand in hand, because I felt like, having strong theoretical and empirical knowledge-based perspective when working in my practice has also been a part of my embodiment of how I am as like a person now. So something that I have been talking like with my supervisor about is like just being like more confident in my abilities and my style and what it looks like and what like people can expect from me as a social worker, because having met so many at this point, with the panel discussions and our professors and things like that, it's very clear that every social worker, like every human being, you know, has their own personalities and has their own style. And even though we may all follow showman skills and competencies and ethics and things together, that everyone differs their own way. And so it really, and some very far left and some very far right. And so really finding like what my style is going to be, because I know like at my last internship, I was a little more lax, you know, based off my population because I was working with teenagers. Now I feel a little more maternal because I'm working with children, like really young children. So I just feel like, you know, finding like where I fit has been really important to me this last year, and especially before applying to jobs, because like I really want to know like what my values are in my practice, to, you know, in order to present myself the way that I want, so that I know what values I have and whether they're going to match up with the job that I want or not. You know, so like that's become like really important to me and like priority on my plate. And another thing would be strong theoretical and like empirical knowledge. It's not something that I thought early on like I cared a lot about. I knew it was important and I needed it. But now, like, I've seen so many people just like say things without backing. Like, I'm just like, why is this not like in the front fort of your mind that like how do you not know you just made this up? You know what I mean? Like, how do you not know? You know, there could be one article about it, never cited again, you know, never like, nothing like really validated, you know, like none of these things. And I find myself like getting very frustrated, and I realized it's because evidence base is important to me, and knowing that there's backing for things is important to me. So like even working with my clients now, as we're going through treatment plans, like with my supervisor, I'll be like, you know, I want to look up, you know, this thing and that thing and that thing and that thing, and see if these things like actually work before I go into the room with him and, you know, practice them. You know, and so even though I know like breathing techniques like help reduce anxiety and stress, I know those things. We all know those things. Someone who's not in evidence-based stuff knows those things. But like I like to go back and say like, okay, what else can I add on to that? What else can, you know, support him? So that's something that I found has been important to me. Yeah.
Your social worker toolbox.
Yes, my tool.
Toolkit.
Of all the reading / viewing up until this point, what was the most helpful / relevant / interesting? What, if anything, have you already applied to your work at your placement? Cite the particular reading or video, not formally, but in your conversation.
I thought the ACE video of the Black lady was very, very interesting. That was the most fascinating to me.
Mm-hmm.
I haven't been able to use that in my internship placement yet. Also, the Columbia scale was interesting to me, but those two were my most interesting. But I haven't been able to use them in my placement yet, but they're always in the back of my mind to see if I can pull it out somehow. But they were the most fascinating, especially the ACE study, because I didn't realize how I kind of knew like your mental health can affect your physical health, but I didn't know trauma could drastically affect your physical outcomes. Like that was like 1,200 or 12,000%. I can't remember, but it was some drastic increase, like exponential increase in suicide or heart troubles or stuff like that. That just blew my mind, because I just know people who have gone through that, and I'm just wondering what their health outcomes will be. And I am luckily haven't had many of. I took the quiz and I didn't have that many. I think I only had one. But just thinking of people who have had like 5 or 6, I'm just like wondering what their outcomes will be and whether or not they'll be okay if they actually have dealt with that trauma or not. So that was interesting.
I think ours was both about the lecture, so you could go first if you want.
Well, yeah, mine was about trauma too, and especially just like I've always been really interested in trauma. I think that's like the whole reason I like got into psychology and social work. Like I'm just really interested in like how other people experience trauma and how it affects them, and like how we can like help support them through it. But then, especially when thinking about my population, I've like used a lot of what we learned, just trying to utilize that trauma-informed lens when speaking to clients, like trying to be more understanding, like what happened to you, not like what's wrong with you type of thing. Especially when clients can be really combative with you and argumentative with you, and you can't take it personal. You have to just stay curious. That's like something we always say at our internship is just stay curious, like don't take it personal, stay curious, because it's really, I mean, maybe it could be about you, like if you did something to offend them, but even that can be like a conversation starter, like what happened, what went on, things like that. And then especially like when I think about ACEs, so my colloquium idea is kind of related to ACEs. So like I'm just really curious about how many of my clients or our population in general have experienced, like what their score would be on the ACEs things. I wonder if there's like any connection, between like a high A score and like becoming homeless later on in your life. Like that's something I'm really interested in exploring at my internship, and I think there might possibly be an opportunity, but we'll have to wait and see.
Yeah. Something that I really liked that we talked about in the lecture was trauma when she was talking about the different types of trauma. And I wish we expanded on it more, but I know we did mostly micro work, was macro trauma and like what it looks like on a community level. And the reason that that's so important to me is because I feel like it's not considered as much. Like when you, like, I feel like I've talked to a lot of people, not social workers, but like, a lot of people in helping professionals that work with other people that don't tune in what it must be like for that client coming in from their background. And it's not to be like assumptionary and say like, oh, they're Black, so they must, be dealing with trauma from blah, blah, and blah. But just considering that and knowing, but that also means that you have to be educated about social justice norms and what, what social justice looks like in our society, and so that's another part of education that's required. But I think community level trauma is something that everyone should consider in their practice whether it's a doctor, a social worker, whatever. Just consider those things coming in, and do your best to do research on what it might be like in someone's shoes from that community or from that population, because you never know what might affect their decisions about. You'll know because they'll tell you afterwards, but what might affect their decisions about treatment, what it might, in the doctor's office, are they going to take medicine, all those things that you can really get sometimes from an intake form, so.
I never think about, I always forget about I mean, we just rarely talk about it, so I always forget to think about it. And I feel like that's especially true when thinking about like the political environment that we're in,
right?
And
Exactly.
the families that we work with, and like I know like I'm Mexican American, so I'm really sensitive to that. So like I'm in tune to that just on a personal level, but I don't ever think about it. It sounds bad, but like I forget about that sometimes with other populations outside of my race group.
Right.
And like it's hard, especially because we rarely talk about macro and like community things. I'm like, that's so true. Like I need to do better at thinking about that.
And that's just like in everyone's like self-awareness, like what you need to keep in mind, because like, and even like with me, because it's like as you're saying, like sometimes you don't think like outside of your own race, like there's so many other cultures that are being separated from their families too that are coming to America, but obviously they're not televised for whatever reasons, and it's only Hispanic, but like there's so many other ones too. So like if you have a client from, this is random, but like Saudi Arabia who came in, and I think it's safe to consider that they could have dealt with separation from their family. They could have dealt with harassment from TSA. They could have dealt, like whatever it was that they came in here from. If they're migrating here, there's bound to be, because our country's not welcoming. So just thinking about all of those things and what their experience might be like. So I don't know. I think it's something that's not considered as much as it should be. And we kind of like just talk about it and go over it in class, but I'm happy that she brought it up in our lecture briefly. So, yeah, that's it.
The end.
The end.